Welcome to Complete Kids Online, friendly discussions about autism and other developmental disabilities. Learn how working together is working better, one conversation at a time.
Hello, welcome to Complete Kids Online. I'm Gina.
And I'm Bob.
And we are joined by Dr. Daniel Wells. Dr. Wells is a licensed psychologist with Complete Kids.
Thank you for having me.
Thanks for coming.
So let's start off by a little bit of your journey in psychology. How did you start and end up in ABA?
Always been interested in psychology. When I got started, professionally, started in graduate school, I was at Duquesne University up in Pittsburgh in their school psychology program. So my first interest was just working within the school system, identifying educational disabilities, learning disabilities, the ADHD, but also children with autism. And so was working within school systems in the area for 6 or 7 years, but then just saw that especially our children with autism just needed some more of that intense service, and I wanted to help out with that and help identify autism and autism spectrum disorders more from the medical side. And so I reached out to Complete Kids here to do evaluations and some support with our ABA therapy, and so got into this work here.
Awesome. I'm assuming that maybe people that are in that position now that you were in back then maybe don't know that this is kind of an option for someone coming out of school, that, you know, it doesn't necessarily have to be within the school system. It can be with a program like ours.
Yeah, I think from a psychology end, it seems like we have two groups of people, some that like the assessment and the diagnostic side of it, and some that like the direct therapy, more of the talk therapy or things that you think of more as kind of traditional psychology. Mm-hmm. So I really like the assessment. I like the, sometimes I call it the puzzle, like trying to understand where kids need some support. And so I like that assessment piece, kind of put those pieces together. And it's nice that Complete Kids offers that therapy and support directly. So I'm not just, I could work in a private practice type of sense and just say, hey, you have this problem, good luck, go solve it. So working with some place like Complete Kids where we can actually diagnose the challenge of autism, but then also provide a service that can directly help and support. And so that professionally is really rewarding.
Well, I've also seen firsthand of you in a non-assessment, like kids that you've already done assessment on, keeping an eye on those kids in the clinic after the assessment. So I obviously, like to your point, is you get to see these kids a little bit further along in the journey than just the assessment.
Right. So what's a nice thing, as a licensed psychologist, I get to work closely with the BCBAs, meeting with them and discussing more of those treatment plans and problem solving about how do we address the problems in the clinic. So you're right. It's nice that I don't just get to see them once and be done. I do get to follow up with some of these kiddos and really see their progress through the eyes of our BCBAs, and so that's really nice.
It's like being a detective.
There you go. Yeah, I hope so.
So what does a psychological evaluation look like?
Well, it is a long process. So
could you take us through that? Like,
sure.
Okay, I go to my doctor. My doctor says, hey, Bob, your son is, we're thinking that maybe we need to get him assessed. So, what does that typically look like for a parent?
So for a place like Complete Kids, we are referral based. So parents can't just call us up and say, hey, I want an evaluation. Typically, the place to start is, as you said, with the pediatrician. And so the parent or the doctor has said, hey, there's some differences here. There's some delays in certain developmental aspects. And I think more evaluation is warranted. So you would call our awesome admissions team, and they would set you up as quickly as possible with one of our psychologists here on staff. And you would come in on that day of the appointment, really just with the parents and the kid. Oftentimes mom and dad come. I've had mom and dad and grandparent come, but really just someone who knows the child and can speak to their history, and then bring the child with them. So that's really all you need. And then
do you have a preference if it's just the one parent, or you don't care?
More information is always helpful.
Okay.
So different parents. even within the same household, have different perspectives on their kid. So yeah, I love working with all the people. Bringing your whole aunts and uncles and extended family. I don't know that all that is needed. Then we're dealing with a lot of conversations all happening at once. But we like to. The point of that evaluation is to go deep on the kid, and so we want the perspectives, all the perspectives that we can get. So on the day of the appointment, you'd come in, fill out some paperwork, and then we would meet with the parent and the child together. We go, as I'm saying, as deep into the child's history as we can. A big part of autism is knowing communication delays and socialization delays, and so we want to get as much background information as we can to say where has that development hit, as far as what are we able to do and what are some delays that we're still experiencing. So a lot of that is conversation with the parent. But in the meantime, we have toys and stimulus in the room where the child, I get to see what the child likes to do and how they interact with me as a new person. And I try and put the child in different situations that helps provide some behaviors that are indicative of autism. And so, sometimes during that appointment, it feels like we're just talking with the parent, but the whole time I get to see how's that child patient? Do they wait? Do they ask for help when they can't open a toy? When I call their name randomly, are they able to respond to me? So lots of different kind of strategies that might just seem like play or might seem just like a typical interaction are actually very informative and help us make that diagnosis. So that appointment usually can last between 2 to 3 hours. Again, we got a lot of things to go over. Typically, our older students take a little longer than some of our younger ones. And then after that, we try, if the symptoms are pretty clear, we'll talk about what we're seeing and say, here's some recommendations for moving forward. There have definitely been some situations where I say, hey, I need to think on this one, and I need to go back and review some of the responses from the parents, and really I'll give you a call to discuss kind of what we thought that outcome was. So for every case, though, after the evaluation ends, we prepare a report. Typically takes 2 to 3 weeks to get a report written just to move through all those appointments. And that report then goes to the insurance companies, but also back to the child's pediatrician. So we send that back to whoever sent that referral to us, and we send it to insurance companies, especially if the recommendation is that ABA therapy is warranted, because that report will provide that justification for why that service is needed. And so then that approval from the insurance company kicks off the next steps, and we can get into that or not. But,
we can, yeah. So then it becomes, we'll get into that in a second, so then it becomes ABA therapy.
Right.
Can the doctor, so is the doctor actually the one, after he looks at the assessment, make the determination, or we're making that, or you're making that?
I get to make that recommendation. Okay. Yep. So,
and I'm going to assume 99% of the times the doctor goes along with the recommendation.
Yes and no. I think as soon as they've referred them to us, the doctor recognizes that we're the experts then in this area. Mm-hmm. So the pediatrician does not have the final say as to whether or not we would get that service.
Got it.
The pediatrician could provide counseling and say, hey, I think this service might be better, but ultimately then it becomes the parents' decision as to whether or not we want that ABA therapy to move forward. Mm-hmm.
Going back to, you said at the eval you have toys and stimuli.
Yeah.
What are some signs that you would see using those stimuli that might suggest that those are symptoms of autism?
Or even something I think what Jean's getting is, even at home, like as a parent, what can I look for?
Well, and I'll say parents at home are a little different. So really what I get to see a lot in the evaluation is how does a child communicate with me and how do they interact with me. Communication and communication delays are a big part of autism. So if in our more severe cases, maybe that child's just not talking at all. And so by the time we're 3, 4, 5 years old, if we have no words, that's one big red flag to say, hey, autism may help describe this behavior. The other thing that we look for are just styles of social interaction. So again, our severe cases, that child might not be interested in me at all. Sometimes we've talked about I might as well be a chair. They don't see me as a person. And so when parents are at home, if consistently your child has little or no interest in other people in their environment, or only use those people in order to solve a problem, like, hey, I know you can open this juice. That's an interaction, but it's not an interaction with like a person with trying to form a relationship. So those stimuli in there, some toys are hard to open and some toys need help. And so we look at how do they approach me for help? Maybe they're too friendly with me. Sometimes another challenge of understanding social interaction is personal space, right? Like we need to make sure we're maintaining that bubble that we all kind of feel. And so if a 5-6-year-old child is crawling up into my lap to get me to open this toy, that's just a sign that they're not understanding social interaction like we would expect. So situations like that, do they use the toy in a typical manner? So a good number of our kids with autism really like organization, and so maybe they'll line up their set of cars rather than rolling them or creating some pretend situation where they're driving in a city. It's just organizing. Or do they use a same toy repetitively? Are they just pushing this button over and over, and they can sit for 20 minutes and just activate this single toy? And sometimes our kiddos don't engage with toys at all. And so that's also data that we're saying, sometimes we've had kids come in and they have a string, or they have a piece of building material or something that they're just, this is their toy.
We would say that a lot too, like during speech. The kid would rather touch the wall than play with all these really fun toys on the floor. Or the outlets, unfortunately, are a big fun thing.
The drawstrings of
lamps,
of blinds.
Mm-hmm.
Got to tuck
all
those
dangerous
up.
things.
Yeah,
it's great.
things, yeah. So again, we're just looking for differences. My training and psychologist training is understanding what typical development is, and autism often manifests with a lot of developmental delays. So we know we have these set of toys and these set of stimuli, and we say, are they just engaging with that differently than we would expect given their age and developmental level?
What about after you started getting into before? So I bring my child in, and Dr. Wells says yes, we believe that he has autism, and then explain what happens then.
Yeah. So my role is to determine whether the service is needed. And so I get to prepare that report and have that meeting with the parent to say, I think I recommend that this service would be helpful for your child. Again, after we get that approval from the insurance company, and then I should say we have a very high rate of saying, like, if I send that recommendation, it's very likely going to be accepted by that insurance company. And that I should back up to say, and that's why a pediatrician will send a referral to us, because most insurance companies require that someone specialized in this area provides a signed recommendation for this service. And that often is sometimes true for that developmental behavioral pediatric. So even doctors who are specialized in autism and give very accurate diagnoses, for insurance purposes, they require someone with my credential or a psychologist credential to provide that recommendation. And so that might also be why you referred to us. So after we send that away and receive that confirmation back, we will schedule a meeting with one of our BCBAs. That stands for a Board Certified Behavior Analyst. And their role is to develop the specific goals and time recommendations that will be necessary to meet that child's needs. So it's another evaluation piece where they'll come in and get to know that child and do some assessments, again, about what functional level they are currently at.
What is some of the time commitments, I want to say, oh God, I'm Prescription. Thank you. But I know that's not the right word.
What do we recommend? Yeah. So ABA or applied behavior analysis therapy is a very intensive process. So we are good at helping with communication and socialization and a lot of those daily functioning or daily living skill needs. But in order to do that, we need time and we need a lot of buy-in from both the kid and the family. So we recognize that it is an intensive process. With that, typically the fewest number of hours that we would recommend is about 15 hours a week. And really that's for our older kids, maybe with milder symptoms or students or children who have received their services in the past and have mastered a few of those foundational goals. I would say the most common recommendation is about 20 to 25 hours a week. So this would be typically every day. We have a morning session and an afternoon session. So the morning session is like 8 to 1, and the afternoon is about 1:30 to 6:30. So every day a child would come to us and work for that amount of time per day and per week. So we do make the recommendations in hours per week. We try and be flexible about how we fill those hours, but just on staffing and everything restraints, we do have these sessions that we try and stick to as much as possible.
Some of those tougher cases you were talking about where you have to stop and think about it a little bit and tease it apart from other disorders, what would be something that would distinguish autism from like a learning disability or something else?
Yeah. Well, and I don't see the difference in learning disability too often. What I see most are what is purely just a speech delay versus a global experience of autism. So as we've said, speech differences is something that is a huge component of autism, but we also know that children can also just have a speech delay. And so some of that, especially with our younger children, it's a lot about differentiating what are those social interactions like? What are the repetitive behaviors or the ways that we engage with our environment? Is it only that we're just not communicating the way we should, or is it more of a global interaction delay? The other thing that it's often kind of confused with is anxiety. So is this child someone who just does not understand social interaction, or are social interactions frightening or uncomfortable to that person? They understand what they should do, but it's just scary to do that. And so a lot of times that shows up with separation anxiety, which is its own diagnosis, a separation anxiety disorder. And understanding that type of the style of interaction, and that can be challenging to parse out.
And I hear a lot in the clinics about early intervention, about diagnosing kids earlier because it's better. Just give us a.
So again, I think that is a lot about the fact that autism is related to developmental delays, and so children with autism develop some of these skills that we all as humans tend to develop at a different pace than some of their peers. So if we start earlier, we've started at a place where they've had fewer developmental expectations. So if we start at 2 or 3, maybe they're only a year behind. And so we have our therapies that can work to help get that developmental progression happening at a more typical rate. If we wait until 5 or 6, now maybe we're 2 years behind, 3 years behind. And so it just takes, there's more ground to cover as far as being able to help our children get back on that typical developmental
But
progression.
I assume I'm guessing, you're going to tell us.
Yeah.
Is it more difficult to diagnose earlier?
Yes.
Yeah, I would think so.
For me, anything before 2, I think is really challenging. I think the children that are diagnosed that early are very obvious. So just as we're saying, talking about the no recognition of another person, or very repetitive and noticeable behaviors that have happened for a long time. Likely no words or no interest in speech at that point. So yeah, the kids that we are seeing at 2 and 3, likely your pediatrician or the parent's pediatrician has been like, hey, we need to get this looked at.
Because it's severe enough, I guess. And we've seen it, I mean, not me and Gina, well, maybe Gina personally, but not me, but I've heard of it in the clinics where a kid will hit his benchmarks and then all of a sudden regress.
Early on in age, yes, for sure. We, when I'm testing 2, 3, 4-year-olds, if I were just off the top of my head, I mean, 30 to 50% will talk about a severe regression where you're like, man, they had these words and then the words just disappeared. Certainly not every case, but I would say a good number. Yeah, a good number will say, man, they were doing these things and then they just stopped.
I wonder why that is. And
as not a researcher at this point, I sometimes in the evaluations I'll get that and I'll say, I can't.
Oh, the parent will ask.
The parent will ask,
which I get.
What's this comment? And I'm like, I wish I had a better answer for you.
Well,
no, for me,
for the rocket, us either.
There's so many. I think there's a lot of work being done on the genetic components, and part of the evaluation is learning more about family history because of some of these autism type behaviors and diagnoses do run in families to a degree, or at least the research shows that. And so there's some genetic component that's going in there.
I was shocked that it's mostly boys.
It's
like a high percentage of boys.
I think about 75%.
Yeah, that shocked me. I don't know why. I just didn't think of it that way.
And the girl. It's interesting you bring up the gender differences because the way that the symptoms can manifest do look really differently because girls are typically, especially in younger childhood, more verbal and more.
And they progress typically faster, right?
Yeah.
My wife reminds me of that constantly. Evidently, that stops happening in your 90s.
Okay. Yeah. That's so. So the girls may look more typical in some areas, and so it can be somewhat more challenging to diagnose. Where we see those girls come across a lot later in development because that's when some of the differences start showing up. So the gender differences are definitely there.
Yeah, I always wonder about why the regression and also why some things are so prominent, like lining of cars and spinning of wheels.
And so we heard trains and fire trucks. Like we're sponsoring the train museum for that reason because a lot of the kids dig trains for whatever reason.
Yeah, it's just so prominent.
Yeah.
There are real sensory differences that are related to autism, and so some of these things I think are related to. Again, I don't personally know the reason, but just the way that they process their sensory environment is just different from many other children. And so we see a lot of kids who love to watch things spin or that they themselves like to spin around. And so the way that they're processing their sensory environment is just those things and those atypical behaviors help them feel more comfortable. And it's just soothing and stimulating for them. We talk about self-stimulating behaviors.
It seems like that's a big percentage of it. It's just something that feels good.
It's right now, this is going to be way too TMI. This is my son.
We love this.
Yeah, this is my psychologist. My son. I have a 10-month-old right now. He's awesome, but I see some of the hand waving behaviors and some of the different behaviors that at 10 months old is developmentally appropriate. That it feels good. It helps me regulate my body. And so I see that I'm like, oh man, I see those types of behaviors at work. Now I have no real reason to suspect that my son has autism right now. And so it's interesting. It's just reminded me that a lot of the behaviors that our kids with autism show, it's a developmental issue, that the behavior itself at some point in development is something that we all do. We all soothe ourselves by waving our hands, or we all put things in our mouths to explore the world. It's just typical development has us moving past that skill. And there are pockets of development where our kids with autism just haven't moved past that skill yet. And so that's where the therapy comes in, that says, here's what typically a child your age should be doing. Let's reinforce, let's teach you that this is what we need to do to move past some of those places where you're stuck.
Mm-hmm.
I'm not putting that high up on the TMI index.
Yeah.
I was waiting for something really good.
You know, as stereotypically as a psychologist, everybody's always like, "Oh, you're analyzing me." I don't analyze anybody else, but I analyze my own kids, I guess. So that's.
We did an ad a while back for looking for an LP or an LPA, and it said, you know, we always do these checkbox things about two things that, you know, are typical of that position. We said when a celebrity walks into a room, you analyze everybody else in the room as opposed to looking at the celebrity. That's a typical LP.
Yeah, just noticing it all. Yeah,
you know, this is just me looking at this as a layperson. That you hear about the increase of, you know, now it's 1 in 50, 44,
Yeah.
and at one point it was 1 in 2,000 or whatever. Mm-hmm. So part of that obviously is that we are diagnosing better. But is there any other?
Oh, again,
I know these are all theories, but
we're just chatting.
And
this is coffee talk.
Those are stuff that you know, not being immersed in that research, you know, I'm not going to be able to speak knowledgeably to. I think the biggest one that I'm aware of is that we're really diagnosing people on the higher functioning end more frequently.
That we didn't just didn't before.
We just didn't before.
That makes sense.
There are, you know, elementary, middle, high school, adult individuals who before may just been like, man, that person does things differently. Mm-hmm. And now we're saying, well, that actually matches the diagnostic criteria of autism. Yeah. And so I think we've always, or more consistently as a society, identified those individuals at the lower end. Mm-hmm. And I'm not aware that there are huge growths in diagnostic rates of that population. It's more of that higher functioning end that we say,
so it's not the fluoride in the water or anything like that. I was hoping it was something controversial.
I know there are a lot. Yeah, I'm not dipping my toe in that. No. So there are lots of theories, and So as a psychologist, and what we talk about is understanding and monitoring the difference between correlation and causation, mm-hmm. right? So, you know, the vaccines is a big one.
Yeah, I hear that a lot.
You hear a lot about the vaccines.
Tylenol's coming up as a big
one.
Mm-hmm.
I've heard that one recently. And so, sadly, the point at which we're diagnosing autism, as we say, around 2 to 3, developmentally, that's when you start noticing things being different, mm-hmm. right? And it's also the time where you're getting these big vaccine dosages.
Right.
And so just timing-wise, just in development, here's where we expect our kids to start talking. Uh-oh, my kid hasn't started talking. Yeah. Also, 6 months ago, they got all these vaccines. Mm-hmm. And so, you know, did those things just start by chance happen at the same time versus what caused.
Well, that's like you wake up with a cold. It's like, well, does sleep give me a cold?
Yeah.
You know, you can't really put those correlations together.
Yeah. So I as I said, I have to be clear. I am not in that research and enough to know or make knowledgeable statements. But that would be my only statement on that. Mm-hmm.
That was just a curious thing.
Yeah.
You want to ask the wrap-up? I always ask the wrap-up. You never ask the wrap-up.
Making me work today.
Yeah, exactly. Earn your keep.
So, you know how we have the superhero theme throughout our clinics and throughout Complete Kids. So we like to ask all of our guests, if you had a superpower, what would it be?
Man, I put a lot of thought into this and
that makes one of us.
Wrote out and then I can't remember what I thought about. I love the idea of teleportation.
Yeah, that's a good one.
Yeah, just, you know, the commute into Charlotte. I would love to.
Oh, yeah.
I'd
that's
love
for
to,
sure.
to cut that down.
Guy that came into Baldwin today, I totally sympathize with you on that one.
Yeah. So, but yeah, just to be able to see family and spend more time doing what I need to be. The car isn't a very time effective place for me. So
no more TSA lines.
TSA lines.
Well, that's it's like I'm not afraid of flying. I just hate the process of flying.
Mm-hmm.
Like I'm not afraid. I never was up there going, oh my God, I'm gonna. But just the whole TSA line, the
Shoes,
waiting, the stuff.
liquids.
Yeah, everything going. Delays. I just the whole thing. I can't take it.
Just let me be there.
Yeah.
There's too many beautiful things to go see.
Exactly.
Yeah, I just want to go do it.
IAN's much lower. I said to not wake up with a hangover. That was my superpower. But my bar is low.
Yeah. Well, I mean, that would also be helpful at times. But
Well, thanks for coming in. We know you're busy with your stuff, but we appreciate you taking the time out to talk to us and hopefully educate some of the audience out there.
yeah. Well, thank you for having me. It's been fun.
Of course.
Great.
See you on the next episode. Bye.
To continue the conversation, visit the links to our website, Facebook page, or Instagram in the comments.